Hi, my name is Sarah Reed. I'm here in beautiful Honolulu, Hawaii. I work at Retina Consultants of Hawaii. I'm going to be talking today about complex cases in retina and the use of multimodal imaging in these cases. So all of the patients that are presented here today were seen in our clinic either by me or one of my partners, Greg Kokame, Jim Lai, or Raymond Wee. They were all taken on the ZEISS camera systems. I'm going to sort of do a combination of case presentations as well as just some image series that really highlight some of the uses of the CLARUS 700 and the CIRRUS 6000. So we'll start looking at peripheral retinal diseases, looking at wide field imaging, then vascular pathology. And one of the things I'll highlight here is the close detail you can get using the CLARUS on angiography, as well as using the CIRRUS both for high detail as well as montage viewing. One of the nice things about the CLARUS is that in addition to wide field, you can also look at finer detail, and we'll see this when we're looking at optic nerve pathology. The true color allows for more realistic imaging, and so we'll see that when we're looking at choroidal pigmentation disorders. And then lastly, we'll focus on the macula, looking at choroidal disease. And you'll see here that the CLARUS can do really nice macular imaging, and we'll also see the fine detail in the CIRRUS 6000. So starting with peripheral retinal disease, this is just a photo of a silicone droplet after anti-VEGF injection. This is the first case presentation. This is a 31-year-old female who was referred for possible macular degeneration. She had a known history of renal dysfunction and was being treated with losartan. And so on this image, you can see that there's a significant amount of peripheral drusen, which was really highlighted here on autofluorescence, as well as angiography. When we're looking at these sort of cases, we can think about familial dominant drusen, an atypical form of Stargardt's. But importantly, because of this patient's renal history, when we went back, they actually had more severe renal failure, and she had C3 glomerulonephritis. And so this is one of the complement-mediated diseases, which is interesting because both Bruch's membrane and the glomerular basement membrane lack regulators that help to control the complement cascade. And so the thought is that without these regulators, activated complement can deposit not only in the kidneys, but also in the retina, causing drusen. And so this is Glomerulopathy-Associated Drusen. Fortunately, most of these patients are asymptomatic, though they can develop neovascular membranes in about 10% of individuals. So even though presenting younger, we don't usually think of this as patient population that has macular degeneration, but still important to follow these patients. So this is a 73-year-old female who presented with a constricted visual field. She had a history of CNS lymphoma that had been diagnosed 4 years earlier and was currently in remission. And so you can see the large yellow subretinal infiltrates. Fortunately, the left eye did not have any sign of disease. And one of the great things about wide field imaging is, especially in these more peripheral diseases, we can sort of follow treatment over time. And so this patient was being followed with serial MRIs with her oncologist, didn't have any sign of CNS recurrence. And so we treated this locally with intravitreal methotrexate. And so it's important to look for intraocular lymphoma in patients who have a history of CNS lymphoma, as about 20% of the time they can complicate these cases. And so you can see that we were able to follow this patient over time, and she had nice resolution of these infiltrates with return of a normal visual field. Looking at just inherited or peripheral retinal degenerations, the wide field imaging really allows us to follow these cases and aid in diagnosis. This is an example of a 65-year-old who came in with retinitis pigmentosa. This is a younger patient whose mother had autosomal recessive form of retinitis pigmentosa, and you can see here some of the peripheral changes that we sometimes see in carriers of recessive RP. This patient had genetic testing that was positive for a TIMP3 mutation, which is associated with autosomal dominant Sorsby's dystrophy. Though this is a somewhat atypical presentation, normally we see more of a macular pathology, often presenting with severe choroidal neovascularization. But this is another case where genetic testing can be really valuable. Here, the wide field imaging really shows that on autofluorescence, you can see the dropout in the periphery. Persistent plaquoid maculopathy is not an inherited form of degeneration. This is an idiopathic inflammatory retinal disease, and it's sort of thought to be almost a crossover between acute posterior multifocal plaquoid pigment epitheliopathy and serpiginous choroidopathy. These patients need to be treated with immunosuppression. But one of the nice things about multimodal imaging is that on autofluorescence, you can really follow for signs of active disease, as these often show up as a hyperfluorescent border. So this patient has been doing well, is monitored every 4 to 6 months looking for changes. And this is a patient with choroideremia, and this is sort of a progressive X-linked degeneration of the retina. And this is an ongoing area of gene therapy study. There's numerous clinical trials that are currently available right now. So we'll move on here to vascular pathology. This is an example of CMV retinitis. And so for our next case presentation, this is an 83-year-old female who presented with known vasculopathic risk factors. In the left eye, which you see here, she had wet macular degeneration with a disc-formed scar. But unfortunately, in her good eye, she presented with painless vision loss starting just 6 hours prior to coming into clinic. And her vision in this eye decreased from 2025 to 2050. And so in some ways, the diagnosis here can almost be made from the OCT, where you can see that there's a hyperreflectivity of the inner retina. Her exam, however, looked slightly unremarkable when you're looking just at zoomed out view. But one of the nice things about the CLARUS is that you're able to sort of zoom in and look a little bit more closely at some of the architecture here. And so you can see that there's dropout of the vasculature and sort of this segmental defects. On angiography, that becomes more apparent, where we can see this boxcar segmentation and slow segmental flow through the arteries with relatively normal caliber veins. In the macula, there seems to be a single artery that doesn't show this pathology. On OCTA, we can actually see where there's a significant amount of dropout of the capillaries in the inferior macula. The cilioretinal artery here is still patent, and so that's why there's still relatively good vision in this eye, even though we can tell that there's been a major vascular insult. And this area of normal blood flow corresponds to the area on OCT where we don't see the hyperreflectivity. And so this patient was taken to the emergency room where an MRI showed multiple strokes, and she underwent an emergent carotid endarterectomy. And when she came back in to see me in clinic, now all of a sudden we're seeing the classic whitening that we associate with artery occlusion. And so this is a central retinal artery occlusion that presented so early that without the retinal whitening. But here the imaging really clinches the diagnosis. And here you can see the area without retinal whitening corresponding to the cilioretinal artery, and on OCT, the area with the normal retinal architecture. So this is an inferior to superior cut on the scan here. And so one of the things that's important when you're looking at artery occlusions is that there's actually been a slight change in the recommendation here for immediate prompt referral to a stroke center. And this is if the patient is coming in with a symptomatic artery occlusion within 24 hours. So these patients are at higher risk of developing either having a stroke currently or within the next week or so. And so if it's within a subacute 24 hours to 14 days, then you can get them in within a couple days. If it's greater than 14 days, then the workup can be done as an outpatient. Vascular risk factors, which she had, you always want to make sure you're asking about giant cell arteritis. There's no specific therapy for retinal artery occlusions. And so importantly, it's important to follow these patients. Unfortunately, she ended up developing neovascular glaucoma and was treated with PRP and Avastin. This is a 43-year-old female presenting with decreased vision for 10 days. When she came in, her vision was count fingers in the right eye and 2150 in the left. And she had bilateral serous detachments in both eyes. Here you can see both on OCT and when we sort of zoom in on the fundus imaging that there are these sort of large multifocal, multilobulated serous detachments. And so when we think about serous detachments, probably the most common ones that come into the clinic is CSR, central serous, but it's also important to think of choroidal inflammatory diseases such as posterior scleritis, sympathetic ophthalmia. We can also see this in malignant hypertension or idiopathic uveal effusion syndrome, collagen vascular disease. In this particular case, the sort of multilobulated form of the serous detachments helps to give us a clue as to the diagnosis. One of the beautiful things about the imaging here is that you can actually see these smaller peripheral serous detachments as well. The angiography really highlights one of the key findings in this disease, which are these pinpoint areas of leakage. And you can see that here out in the periphery, but then also around the nerve, these pinpoint parapapillary areas of hyperfluorescence are actually a good prognostic factor, indicating that this disease is in its relatively early stages and so may have a better response to treatment. In the late stages, we can see the pooling in the serous detachments of the dye. And so this is an example of Harada disease. So VKH is a severe bilateral granulomatous choroidal inflammation that presents with additional neurological, auditory, and integumentary findings. Harada disease, or probable VKH, occurs when you just have the ocular findings. And so important things to make this diagnosis, they need to have no history of penetrating trauma and no other evidence of ocular disease or an inflammatory condition that can mimic Harada disease, such as syphilis, TB, or sarcoid. This patient was treated with oral steroids, and you can see she had a dramatic improvement both in the OCT and in her vision. And that's really the final test of this disease since it's very steroid responsive. So looking a little bit more at sort of angiography reading and vasculopathic retinopathy, we can add in OCT angiography to sort of get a better feel for some of the vascular structures. This is non-proliferative diabetic retinopathy. And you can see that this particular patient's vision is primarily limited by enlargement of the foveolae vascular zone, as well as diffuse capillary dropout in the periphery. This is an example of a patient that was treated with laser for proliferative diabetic retinopathy. And you can see that there's significant peripheral capillary dropout and attenuation of the capillary structures on wide field imaging. This is a patient who came in with very severe non-proliferative diabetic retinopathy. IRMA, which we'll see here, is one of the defining features of severe non-proliferative diabetic retinopathy based on the 421 criteria from the early treatment diabetic retinopathy study. And these are thought to be shunt vessels that cause abnormal branching or dilation of the existing capillaries. And so we can see one of the other findings in NPDR, which are the formation of microaneurysms. But then here, where we see this intraretinal microvascular abnormality, the diagnosis is really made by the absence of leakage on angiography, which indicates that even though this is remodeling, we haven't seen the formation of new nascent neovascularization there. This is a patient who sort of progressed to the next level. This is a low-risk proliferative diabetic retinopathy. This patient also has diabetic papillopathy, microaneurysms, and venous beating. And so one of the nice things in this particular image is you're able to capture all of these findings using a single imaging source. And so we'll start by looking here just at the optic nerve, as well as this area where we can see some abnormal vascular layers. And when we look at the late phase, here we can see that we're having leakage at the disc. So this is the papilledema that I was talking about. And then that this area here also leaks, which indicates that this is an area of small neovascularization. In this same patient, looking in the periphery, we're able to see microaneurysms and venous beating. And this is sort of a beautiful example of how you can see these other microvascular abnormalities. Venous beating is the third criteria for NPDR in that 421 rule. Proliferative diabetic retinopathy can progress, and in this case, we can see in the left eye, this patient was treated with peripheral laser. In the right eye, this was determined to be an inoperable retinal detachment. You can see an almost complete funnel coming from the nerve. We can see here neovascularization of the disc, but importantly, we can also use OCT angiography as ways to visualize other vascular abnormalities that otherwise can be harder to diagnose. And so in this particular example, we'll see going through the layers of a retinal macroaneurysm, and you can see here the blood flow as well as the macroaneurysm visualized really beautifully here on OCT angiography. Peripheral imaging also allows us to find vascular abnormalities that otherwise can be more challenging to pick up on imaging. This is an example of a Hollenhorst plaque. About 3/4 of these are actually asymptomatic when we see them in clinic, but they're important to diagnose because they can indicate an ipsilateral carotid stenosis. And so it's important to refer these patients for a workup that can be done as an outpatient. This is a branch retinal vein occlusion that was treated with PRP for neovascularization. In addition to the area where the patient was treated with laser, you can also see that there's significant capillary dropout in the inferior macula. And that's even more apparent when we look here on wide field imaging. So looking a little more at the posterior pole at optic nerve pathology, we'll start here with a 43-year-old female. She presented with choroidal neovascularization associated with a peripapillary choroidal osteoma. And ultrasound showed echogenic lesion, and this was also confirmed with CAT scan that showed a bony lesion in the posterior lobe. So in these particular cases, you can treat both with intravitreal anti-VEGF as well as photodynamic therapy, which was done in this patient. And fortunately, she had a really nice response here. There's been a few case reports that have shown partial resolution of the bone in the osteoma after PDT. So for these patients, PDT may be a good initial therapy as there may be additional benefits from it over anti-VEGF. This is a patient that came in with optic nerve head edema, came in for bilateral decreased vision, 2400 in the right eye, 20/30 in the left, no known past medical history, and she was referred for bilateral central retinal vein occlusions. I took her blood pressure in clinic and it was found to be 240/140, and she was brought emergently down to the ER. And so one of the interesting things that we see on exam is even though we do see some peripheral retinal hemorrhages and we do see some congestion of the optic nerve, which can be seen in vein occlusions, when we look at sort of the wide field imaging, there's no venous leakage and there's minimal tortuosity, and that really doesn't support a CRVO, even though we are seeing some leakage from the disc. And so this is an example of malignant hypertensive retinopathy. And this is a life-threatening condition with end organ damage due to elevated blood pressure. The patient was brought down to the emergency room and the MRI was consistent with hypertensive encephalopathy, and she was admitted to the ICU. This is important not only because of the high blood pressure, but this condition carries a high mortality without treatment. This is a 47-year-old male, asymptomatic, no past medical history. And so we can see here a slightly tilted optic nerve. And one of the nice things about being able to zoom in here is that we can also see on autofluorescence this optic nerve head drusen. And so this is an example of pseudopapillary edema, and this patient just needs to be followed with serial exams. When optic nerve head edema resolves, as that swelling causes stretching of the tissue, we can see Patons Folds as the fluid resolves. This is a patient who came in with polycystic ovarian syndrome, with pseudotumor cerebri, and chronic papilledema. As her PCOS was being treated, the papilledema resolved, and you can sort of see these watermarks or peripheral folds still present around the optic nerve, so these sort of radial corrugations still seen on imaging. Choroidal pigmentation and changes can occur in a number of different diseases. Seen here, this is a chronic choroidal detachment with a patient with chronic hypotony, but with relatively preserved central vision, and so this patient is just being observed. This is a 72-year-old male who presented with blurred vision in the right eye for 6 months, and we can see here that there's a pigmented lesion, but importantly, it's encircling the optic nerve about 180 degrees. We can look closer at the imaging and see these feathery borders in the periphery, as well as subretinal fluid here, and this is the cause for the patient's decreased vision. We can see hypofluorescence here on the autofluorescence due to lipofuscin. And then on angiography, we can see initially there's some blockage from the lipofuscin, diffuse leakage, and late staining. This is an example of a diffuse choroidal melanoma, which are relatively rare and comprise about 4 to 5% of choroidal melanomas. And it's named because it has more of a horizontal and flat growth pattern. In a review of a little over 100 patients, 26% had developed metastases. And so these are actually high-risk lesions, especially given the fact that this one is partially surrounding the optic nerve. Additionally, the feathery borders that we can see on imaging can also be associated with metastasis. This patient ended up being enucleated and is doing well. This patient was sent in for an unrelated complaint, but was incidentally found to have pigmentary changes in the iris and the choroid. And so one of the great things about the true color is that you can see here on imaging that you can actually visualize the difference in pigmentation of the choroid between the two eyes. And you can tell that this isn't just from a change in the exposure, because in the right, you can actually see the choroidal vasculature a little bit more easily than you can in the left. When you look at the irises of the patient, you can also see that there's increased pigmentation in the left eye, as well as this sort of slate gray discoloration of the sclera. So this is oculodermal melanocytosis, also known as nevus of Oda, and it's an example of excessive pigmentation that we can see in the iris and the sclera and the choroid because of an increase in the normal number of melanocytes. And it's important to follow these patients because they have an increased risk of choroidal melanoma during their lifetime, about 1 in 400, but they also have an increased risk of glaucoma as the melanocytes can invade the trabecular meshwork. So for our last series, we're going to talk about the macula and about choroidal neovascularization. This is an example of myopic CNVM, and you can see these sort of multifocal areas of myopic degeneration, as well as bleeding from neovascularization. And so using the OCTA, it can be really helpful in these cases, especially if you're not too sure what's going on, but also to actually help follow the response to treatment. And so you can see here initially, this is looking at the ICG, but actually the vascular network is even better visualized looking at the OCT angiography. This is an example of wet age-related macular degeneration. On angiography, you can see this is a minimally classic choroidal neovascular membrane. But when we look on OCT angiography, not only are we able to see that vascular network, we're also able to see this intraretinal cysts and some intraretinal blood flow, indicating that not only is this a minimally classic CNVM, but there's a component of type 3 choroidal neovascularization or retinal angiomatous proliferation. One of the nice things about using OCTA to image the neovascularization is you can also follow response to treatment. And so following anti-VEGF injection, you can see that neovascular network has completely regressed, and we can see a more normal contour of the retina. And so this allows a non-invasive way to track choroidal neovascular membranes. Using the angiography comparison, you can actually follow the neovascular membrane over time. And so on the left was the initial, and then on the right, you can see after treatment that the complexity of the neovascular network has actually decreased. So you can see that some of those finer capillaries have started to regress. Sometimes the diagnosis can be a little bit less clear. This is a patient who looks initially like they have central serous chorioretinopathy. On the OCT, you can see sort of a shagginess to the outer photoreceptors. The angiography isn't too clear about whether or not there's a neovascular membrane, but on OCT angiography, the neovascular membrane becomes a lot more apparent, and this patient was treated with anti-VEGF. For polypoidal choroidal vasculopathy, there's some debate about whether or not this falls into a pachychoroid spectrum or whether it's really just a spectrum of wet macular degeneration. It's important to diagnose polypoidal choroidal vasculopathy, as this particular disease can be more responsive to PDT and could have more anti-VEGF resistance. Looking at this particular patient, using the true color, you can actually see that there's a yellow-green vascular lesion right there. And then when we overlay the OCT on top, there's a visible polyp with a branching vascular network that can be seen. And when we look at the OCT, this branching vascular network really pops out. So you can see the superficial layers show the polyp, which we can also see here on the OCT. And then the sub-RP layer highlights the BVN, which can also be seen even more clearly on the deeper outline. And often with PCV, we can actually see better visualization on OCT compared to ICG. And so this is an example where the ICG, it was a little bit harder to see that BVN, but we can really see it here on the OCTA. So this is a patient who has a congenital hypertrophy of the RPE or a chirpy, and there is adjacent subretinal hemorrhage and subretinal fluid. And you can see here on OCTA that we can visualize this neovascular structure. In some cases, as I mentioned, the diagnosis isn't always clear. This is a patient that has non-exudative macular degeneration, but OCT angiography reveals there to be a subclinical choroidal neovascularization. And one of my mentors, Phil Rosenfeld, has studied these extensively and has shown that patients who have a subclinical CNVM have a 15-fold higher risk of developing exudation. And so it's important to follow these patients closely, as they're higher risk than your other dry AMD patients. So this is an example of dry macular degeneration with a pseudovitelliform detachment. And these are important to diagnose because they don't respond to anti-VEGF, but have a relatively good visual prognosis. And so what we're able to do here is look both at the images as well as the OCT, but then on OCT angiography, we can confirm that there's no neovascular membrane. And so some of the clues here are the fact that we do see this sort of junky quality to the subretinal fluid. And that's because this is more due to an RPE dysfunction and a buildup of the photoreceptor outer segments than it is to an exudative process. And so these patients usually can be safely observed, though they can develop a complicating CNVM later. So it's important to sort of keep an eye on these patients. Patients with dry macular degeneration, a lot of times we'll get OCTA to help us delineate whether or not this is a higher risk with a subclinical neovascular membrane. This is an example of a patient that has just dry macular degeneration and so can be safely observed. So for our last case presentation of the day, this is a 62-year-old Caucasian female who presented with bilateral vitreous floaters. On exam, she had vitreous cell in both eyes, and her right eye was 20/40, left 20/20. And so what you can see here is that there are these numerous yellow-white choroidal lesions that seem to be sort of radiating from the nerve. In this particular disease, a lot of times we'll see them predominantly nasally, which is also true in this case. This patient was found to be HLA-A29 positive, which gives the diagnosis of Birdshot Chorioretinopathy. This disease can be harder to diagnose, especially in patients with blonde fundus, where these lesions may not be as readily apparent. And so this is one of the areas where ICG can be really valuable because you'll see these hypocyanescent spots in the later phases. And so you really want to look at the late stage on the ICG. And you'll see these spots often clustered nasally, which is the case in our patient. And so ICG, especially wide field ICG, can be a really important adjuvant when you're trying to diagnose birdshot, especially when it's in its earlier stages. So as with our patient, most of these are HLA-A29 positive. This is an important disease to diagnose because the initial signs can be somewhat subtle. Floaters, some sort of vague decreased vision complaints. But if left untreated, these patients will have a permanent and progressive decline in their vision. If left untreated, about a fifth of these will develop severe vision loss in over 10 years. And it's important to make sure that you're ruling out sarcoid, syphilis, and tuberculosis, as it's important to rule out sarcoid, syphilis, and tuberculosis, as these can mimic some of the choroidal vascular inflammation that we see in birdshot. And so that is the end of my case presentation. Thank you so much for sitting and watching with me, and I look forward to answering any of your questions.